네, 안녕하십니까. 저는 부산대학교 치과보철학교실 허중보입니다.
Greetings, I'm Professor Ho Jung-bo of Prosthodontics Division at Busan University. Welcome to Master Course. Today I'm going to talk about the diagnosis and treatment plan for aesthetic implant prosthesis in the anterior zone. In the case of anterior implant in the upper, it is very difficult to get aesthetic result. Therefore, we need to pay attention in the diagnosis process and when we come up with treatment plans, where the implant needs to be placed and what kind of form should the prosthesis take, what kind of materials should be used for the prosthesis, what kind of abutments need to be used. These need to be considered when coming up with treatment plan. The contents of the day. In placing 4-unit anterior implants, I'm going to talk about how we do top-down method. Second, depending on the bone volume and soft tissue, I'm going to talk about how treatment plans should be formed. Let's look at the top-down treatment plan for anterior zone. I'm going to mention a lot of numbers, and today it's a summarized lecture, therefore I hope you remember these numbers. Ideal crown form. It should resemble natural tooth. In order to do this, implant needs to be placed properly. The depth and buccolingual position is very important. The implant placement position to enable implant to resemble natural tooth is very important, but it's difficult to attain. In order to get aesthetic clinical result, we need to look at the following factors. Harmony with adjacent teeth. It's important, especially if there's no tooth. It's very difficult to determine where to place the implant in order to make it in balance with adjacent teeth. Let's look at the figures. It's different by different studies, but we need to basically understand and memorize the width and the position of the implant to be able to place the implant in ideal position. From the implant, the distance to the buccal bone needs to be at least 2 mm to get ideal result. And to get ideal prosthesis contour. As shown in the middle, if it is placed too palatally, then good emergence profile could not be achieved. It could result in ridge lap as shown in the middle. This can be an issue aesthetically as well as in terms of maintenance. If it is placed too buccally, this will be addressed later, but if the patient has thin soft tissue, on the facial side, recession can occur, and this can be a very serious risk factor aesthetically. This can be especially stressful for young female patients. So from the beginning, as we do treatment planning, we need to understand the bone width on the buccal side and the amount of soft tissue. As shown on the clinical image, if the implant is placed too labially, the soft tissue and labial bone are too thin, therefore we can anticipate recession 100%. If the patient has very thick gingiva, such tendency can occur slowly, but in the end we see these kind of a recession. Once recession occurs, then treating this becomes extremely difficult. Therefore, placing implant in the correct position is very important, especially in the case of upper incisor. Rather than placing it in the center, it is better to place it slightly distally. You need to shift it by 0.5 mm or 1 mm to the distal side. If you look at the natural tooth, the longest part of the cervical area is slightly positioned distally. Therefore, we need to place the implant in line with the form of natural tooth. In general, as we place the implant, we need to stick to the principle of 1.5 mm distance between natural tooth and implant. It may differ depending on implanted type and implanted design as well as prosthesis form, but if you look at the different studies, the distance between the implant and natural tooth should be 1.5 mm. Please take note of this. If you look at this case, when I place the implant placement position is slightly distally inclined. This is not placed wrong. I looked at the natural tooth, the adjacent tooth, and I tried to resemble the adjacent tooth. So intentionally, it was placed slightly distally. Strategically, you need to consider this and place the implant. If you do this, the form of prosthesis could appear more natural. There needs to be 3 mm between implants. This may differ depending on external connection or internal connection or ITI type. Whether it is SST, SUS type, it may differ. However, in general, if you look at the different studies, there needs to be at least 3 mm of distance between implants to get ideal prosthesis form. And this will lead to better implant results long term. Earlier, I've mentioned that there needs to be at least 1.5 mm between implant and natural tooth, and there needs to be 3 mm of inter-implant space. Boozer talks about something very difficult. It can be quite subjective. Boozer talked of safety zone. If the implant is positioned like this, you can get the prosthesis in a very stable manner. It is this area in green square. If it is labially inclined within 1 mm, it does not affect the prosthesis. However, if it exceeds 1 mm, we go into the danger zone. We need to make sure that the connection area of the implant is not positioned in the dangerous zone. There needs to be 2 mm of space from the implant to the buccal wall. This is because of the bone. I've talked about how there needs to be 1.5 mm of horizontal space between implant and natural tooth. This horizontal space is the comfort zone. If you infringe upon it, then you'll fall into the danger zone. This is related to depths. If you look at the green, the bone level with the adjacent teeth, the implant needs to be placed deeper in order for us to be in the green comfort zone. However, if implant is not placed like this, the implant crown will be too elongated. If the implant is placed more towards the incisal than the green area, then this can be a huge problem. If the implant is not fully in, this is very risky. Therefore, we need to pay a lot of attention. To this. From C junction, you need to place the implant 3 mm below that. That is the comfort zone.
보통 한 3mm 내외에서 C 정션에서 3mm 하방 정도로 하방 안에까지 저희가 이제 세이프티 컴포트 존이라고 이제 말을 하고 있습니다.
Angulation can be an issue. In the case of anterior zone, I'm not sure how you address this now, but at times I use cement type in the anterior area, and angulation can be difficult in this case. People with more experience consider angulation because the screw hole needs to be more lingually. By making screw hole lingually, you can get aesthetic prosthesis and ideal emergence profile. For this strategic goal, implant is slightly placed more lingually. This is to make a screw hole more lingually. If you're going to use cement type, it doesn't matter. If you do not place the implant lingually and place it labially, the screw hole will be towards the labial side. The screw hole is very big, 1.2 hex itself is very big. It is difficult to fill it with resin. These days we use a lot of zirconia and the bonding is difficult, so you see the black bit. In this case, if implant is placed more labially, I use cement type, but there's issues with cement type such as excess cement. Let's talk about biological width. Today is about summarizing, therefore I'm going to just put it simply. If you look at the natural tooth on the left, there is a connective tissue below. There's connective tissue and long junctional epithelium. This is a tissue that is below the sulcus. The height of that is about 1 mm. The connective tissue is about 2 mm. If so, you can get very firm connective tissue. This is a very important protective mechanism that protects us. Sulcus, it needs to be maintained by about 1 millimeter. What is really interesting is that these numbers, our body tries to maintain these numbers. If I make prosthesis that violates the biologic width, our body eventually causes inflammation to secure 3 millimeter. With inflammation, hard tissue and soft tissue is resorbed and new biologic width is formed. If you make wrong prosthesis and if the margin is too deep, then it will lead to swelling and inflammation, and biologic width will be changed. Therefore, we need to understand that 0.5 millimeter below sulcus is where we can utilize to make prosthesis. Implant also has biologic width. The biologic width of implant is thicker than that of natural tooth. It is over 4 millimeter. In the case of natural tooth, the connective tissue is attached to cementum and a firm barrier is formed to protect against external stimulations. In the case of implant, soft tissue is not attached directly, and along the long junctional epithelium, the barrier is formed. It is vulnerable. The implant is vulnerable from outside stimulation. Therefore, we try to form a biologic width 1 millimeter thicker than that of natural tooth. We need to understand that natural tooth has about 3 millimeter of biologic width and the implant 4 millimeter. In the case of implant, the connective tissue area is not thick. If you gingicord, then you can cause a serious harm. Therefore, we need to be careful in treating soft tissue. In conclusion, how deep should the implant be placed? I've talked about biologic width being 4 millimeter. From the implant top to the gingival margin, that is the space for biologic width. So below 4 millimeters, that's where the implant needs to be placed. We need to check the buccal bone. The implant needs to be deeper than the buccal bone. If the buccal bone is resorbed, these numbers are meaningless. What I'm talking about is a very sound extraction socket if you have done extraction very nicely, and if the buccal bone is intact. In this case, you need to make placement 3 to 4 millimeters. Please remember this. Interproximal level to contact point. The gingival thickness or height needs to be 4 millimeter to secure interdental papilla. Placement needs to be done like this to get good emergence profile and aesthetic result. I've talked in numbers about how deep the implant should be placed and what kind of tilting buccolingually there needs to be. Please remember these numbers and apply them in your clinical practice. You can modify them based on your experience as well. Upon placement, from the gingival margin, it needs to be 4 millimeter below. In the case of OSSTEM, there is a pre-mount. There's a structure where you can check the 4 millimeter, and it's a major plus. In the pre-mount, below the hex structure, this structure is about 3.5 millimeter from the implant. If you look at this red line, if the implant goes in like this is perfect. Using this notch-like structure would help you get the right placement depth. You need to be aware of these points as you do implant placement. If you place it too shallow, then it can lead to many complications. Serious complications can result. The crown length becomes shortened and the implant might as well be exposed. A lot of plaque can be accumulated and you can see red inflammation here. Therefore, implant placement depth plays a very critical role.
이 치아 주위에 항상 빨갛게 염증이 생기는 걸 우리가 확인할 수 있는데 그래서 깊이 문제가 상당히 적절하게 좀 깊이 식립하는 것이 좋습니다. 그런데 또 너무
If the implant is placed too deep as shown, the crown goes in too much. As mentioned before, the biologic width needs to be 4 mm for the implant. If the implant is placed too deep, the soft tissue will be resorbed. Interdental papilla can disappear. This will make maintenance very bad, as well as negative impacts on aesthetic results can occur. Therefore, placing implants 4 mm deep would be ideal. Second, if you have done implant placement well, you need to determine the prosthesis type. Screw type is actually the best. You don't use cement, and it's very nice and clean. In order to use screw type, you need to place the implant slightly palatal. That would enable you to have screw hole towards the lingual side, towards the palatal side. This is key in having good prosthesis. In most cases, we cannot do that, and as shown on the far right, people use cement type in those cases. Aesthetically, this is not an issue, but if there is excess cement within the gingival sulcus, this can lead to inflammation and other major complications. Screw hole needs to be made towards the lingual side. In the case of ER type, zirconia prosthesis can be used, and after cement is used, intraorally, you unscrew it and then you remove it properly. Do you remove cement? You don't do that. Normally, hygienists remove it. No matter how careful they are, they cannot remove the resin far into the sulcus. In order to do that, you need to open flap. It can be quite dangerous. So from the beginning, maybe you can plan for ER type, or I'm going to mention this later in the lecture, but you can use angle driver to form a screw hole on the lingual side. This is ER type, screw type prosthesis. Use cement zirconia on custom or stock abutment. And through screw, it can be removed. And then you can clean it up and then connect it once again. The third step is if you have determined what kind of prosthesis type you're going to use, you need to choose the material. I have so much to say, but because of time constraint, I'm going to talk about factors to consider. First, you need to consider abutment space. If you make abutment too small, it will fail. Horizontally and vertically, it needs to be sufficient. This will enable more retention. Therefore, you cannot make it too small. The image is slightly small. You need to secure significant abutment space, and based on that, in the past, we did cutback. You need to design final prosthesis and do cutback and make abutment. You need to secure at least 1 or 2 millimeter of space for prosthesis when you do cutback. For material space, we say you need to secure 2 millimeter of space. Abutment is titanium, but because of strength, 2 millimeter of thickness needs to be secured. The height and length needs to be appropriate for the implant to remain in its place. You need to make appropriate abutment contour after talking with the lab technician or the manufacturer. The axis of the implant cannot be too inclined. If you make the abutment too angled or small because of wrong implant placement, the crown will fail. You need to consider these factors. There are so many complicated things to talk about in terms of material. I normally use monolithic zirconia in my clinical practice. I do not use veneer these days because we have great gradation block or multi-layer blocks, and you can use a zirconia for anterior restoration as well. If you use opaque treatment, you can prevent titanium being shown through. Some people still use porcelain veneer. If you do this, you need 2 millimeter. If you use monolithic zirconia, 1 millimeter is sufficient in providing restoration. This 1 millimeter of space is utilized for custom abutment space to get better emergence profile. You need to choose abutment. You need to think of biotype, whether the patient has thin or thick biotype. This is very subjective. If you look at periodontology books, I'm a prosthodontist, but if you look at the textbooks, it's very confusing. What is important is your experience. Based on your experience, you need to have your own set of guidelines in discerning the patient whether the patient has thick or thin biotype. Using that, you need to know when to be careful, depending on central incisor, lateral incisor, and canine. The margin differs and needs to reflect the crown. This can be easily addressed if you use custom abutments. As shown in this patient, if the patient has too thin biotype, even if you make custom abutment, it can see through. You need to make a zirconia abutment. You need to modify it. If the patient has a very thin biotype, changing material is important, but changing the form of custom abutment is also important. We need to think about bone volume and soft tissue volume. Based on these, we need to come up with a treatment plan. If there's lack of bone, you need to do bone augmentation. Vertical bone augmentation needs to be done, but this is not easy. It's quite difficult. But in the aesthetic zone, appropriate implant placement is necessary and bone augmentation is necessary. I've talked about buccolingual angulation. You need to do bone graft to be able to place the implant, and I agree that doing this is not always easy. I'm not good at it.
임플란트를 신입할 수 있게끔 뼈 이식을 하시고 하셔야 되는데 자, 이런 것들이 상당히 어렵다는 걸 저는 인정합니다. 저도 잘 못합니다. 하지만 거기에 대한 고려를 꼭 하셔야 될 거라고 생각하고요.
If you come across socket type defect, in this case bone augmentation is not difficult, but if it is flat or if you do onlay graft, it can be quite complicated as a prosthodontist. Placing the implant and making that 2 mm of buccal bone is quite important. I'm not a good surgeon, but if there's just less than 1 mm of bone around the implant, even if you don't use the membrane, I recommend doing bone graft for bone formation. You need to secure bone thickness. In the case of thin biotype, it can be problematic. As you work with periodontists, no matter how good a job the periodontist does, if you make a smallest mistake, in a thin biotype, recession occurs. I think thin biotype patients are quite difficult. By thin biotype, if you put in abutment, it is shown through. In this case, I call the patient thin biotype patient. What to do in this case? I've talked about complications in thin biotype, but even if you use zirconia custom abutment, if you use a link can show through, almost as if the patient has bruise in that position. It looks black here. There are these kind of patients. In this case, you need to make a zirconia abutment. The problem is that it fractures easily. You need to explain this to the patient and you need to pay more attention in terms of anterior guidance and occlusal adjustment. We need to make sure that excessive excursive force is not applied here. In thin biotype patients, implant placement depth and distance to the buccal wall needs to be emphasized. There needs to be a screw hole on the lingual side. Implant angulation is something that we need to pay more attention. Prosthesis, contour, and screw type. You can use ER type as well. It is important to make sure that there's no excess cement. If there's excess cement, in the case of thin biotype, everything can be resorbed within a short period of time. In the case of thick biotype, there's nothing to worry about. About 0.5 mm subgingival margin is good. After that, provide appropriate prosthesis for the patient. In the case of thick biotype patient, you do not need to strictly abide by the principle, but you need to have at least 2 mm on the buccal side. I've talked about implant position, prosthesis type, and material. I've talked briefly about these topics, I wanted to emphasize a couple of factors.
중요한 점들을 말씀드렸습니다.
I want to summarize by looking at a case. This is a very old case. So when you place implant,
임플란트를 식립할 때
don't look at the buccal bone. Please look at the lower right image. You need to draw a line connecting the center of the lingual surface of adjacent teeth. If you draw a line, if the buccal bone is lacking, do a bone augmentation. Bone augmentation is difficult, yes, but if the implant placement position is wrong, even if you do bone augmentation, it will fail. Look at the black line. This has been formed by connecting the center of the lingual surface of adjacent teeth. Place the implant here. When you take impression for custom abutment or when you do a final impression, customized impression coping can be fabricated. You can cut the provisional and add impression coping, or in the next lecture, I'm going to show you how this is fabricated. If you use this to take impression, the impression material becomes pickup impression and the final prosthesis can reflect this form. This will be addressed in the next lecture. In other studies, it says 1.5 millimeter. But in most cases, you need to have at least 2 millimeter of buccal bone.
대부분 2mm 정도를 생각하셔라라고 말씀을 드립니다.
Please remember the 2 millimeter.
두시길 바랍니다.
If there's lack of bone, you need to do only graft first and then do implant placement. That is my recommendation. Let me tell you another number. The distance between natural tooth and implant needs to be 1.5. Carmish textbook says 1.5 to 2 millimeter.
자, 임플란트와 임플란트
And there needs to be at least a 3 millimeter of inter-implanted distance. In the textbook, it says 3.5 millimeter. If you're going to do a bridge using implant, there needs to be at least over 6.5 millimeter distance between implant. Please remember these numbers. The depth was 4 millimeters, 3 to 4 millimeters. Let me summarize today's lecture.
오늘 말씀드린 내용은
Today, I focused on how to provide an aesthetic implant prosthesis in the anterior area. There are 4 factors to consider in the top-down method. I hope you come up with your treatment plan following these 4 factors, and depending on bone volume and soft tissue, you need to bear in mind what kind of things you need to consider. I've also emphasized about several numbers.
메모리해 주시면 감사하겠습니다.
Today, I've talked about aesthetic prosthesis for anterior implant placement. You need to have a top-down approach, especially for anterior aesthetic zone, and you need to do surgery accordingly. Ideally, there will be enough bone and soft tissue, but clinically, that is not always so. I hope you hone your top-down treatment method and succeed in placing implant in anterior aesthetic zone. Stay tuned for my next lecture. Thank you for watching.